Hey y'all, welcome to Pep Talks with Stu Riggins, brought to you by Pinnacle Performance and Wellness. I've got a talk for the ladies today, or maybe if you know a lady that's going through some of these things, you can share this with her. But we're going to talk about the estrogen and progesterone balance. So at some point in their late 30s or early 40s, a lot of women notice that something has quietly shifted. Sleep starts to feel different. It's not always terrible, it's just not as restorative. Anxiety can show up without clear reason, sometimes a low hum in the background, and sometimes it's much more significant than that. The emotional resilience that they've always counted on feels less abundant. They can have brain fog. They can have a fatigue that doesn't really respond to rest. And there's basically a version of themselves that feels just slightly out of reach. And here's the part that frustrates me as a clinician, as most of these women have already been to a provider. They've had labs drawn and they were told that everything looks fine. But I will say it again, fine is not the same as functional. So today I want to walk you through what's actually happening in the body during this phase and why the standard approach sometimes misses it and what a more complete evaluation looks like. So this hormonal shift, most people think of menopause as an estrogen story. That's the version that we hear most often. Estrogen drops, symptoms follow, and if things get bad enough, you consider hormone replacement. Now that framework isn't wrong, but it can be incomplete. Because for most women, that hormonal shift that drives those earlier symptoms doesn't start with estrogen. It starts with progesterone. And that's often a full decade or more before estrogen meaningfully declines. Now here's why that matters. Starting in the mid to late 30s, ovulatory cycles begin to change. They may still be regular on a calendar, but the quality of ovulation shifts, and that affects how much progesterone the body produces in the second half of the cycle, or what we call the luteal phase. Progesterone doesn't just regulate the menstrual cycle, though. It does something much more significant in the brain. It gets metabolized into a compound called allopregnanolone, which binds to GABA receptors. These are the same receptors that are targeted by anti-anxiety medications. Allopregnanolone is essentially the body's built-in calming agent. So when progesterone starts to decline, women lose access to that neurochemical. This happens gradually and it happens quietly, and it's often in a way that doesn't show up or doesn't look obvious on a hormonal panel. It shows up as anxiety, disrupted sleep, emotional reactivity, and a lower threshold for stress. And when these labs get drawn, progesterone might come back within the so-called normal range, which technically means it's not flagged as a problem. But again, normal range is not the same as optimal, and a single value drawn at the wrong point in the cycle can basically tell you nothing. Now, the estrogen piece is more complicated than it sounds. So eventually, as women move through their 40s, estrogen does begin to shift, but it doesn't just decline in a straight line. In perimenopause, estrogen can actually spike, sometimes dramatically, before it ultimately drops. And that roller coaster pattern is one of the reasons this phase is so disorienting. High estrogen relative to low progesterone produces a state called estrogen dominance. And that's not a diagnosis you'll find in most conventional training, but it's a useful clinical concept. Symptoms can include bloating, breast tenderness, heavy or irregular periods, mood swings, and worsening anxiety, sometimes all at once. And then estrogen does eventually decline and you start to see a different set of symptoms: hot flashes, night sweats, vaginal dryness, cognitive changes, accelerated bone loss. Now, the challenge is that these two phases, the progesterone decline phase and the estrogen fluctuation phase, overlap. They don't happen in a clean sequence, and the symptoms blend together in a way that makes it easy to write off as stress or burnout, or worse, just aging. That's not a patient problem, that's an evaluation problem. Now, in regard to estrogen dominance, there is a condition that is specifically worth mentioning, and that is endometriosis, because it illustrates everything that we've been talking about in a very concrete way. Endometriosis is an estrogen-driven disease. The tissue that behaves like the uterine lining but grows outside it, on the ovaries, the bowel, the bladder, the pelvic wall, it's estrogen dependent. It grows in response to estrogen. It's sustained by estrogen, and the pain and the inflammation and the progression of the disease all track closely with estrogen exposure over time. Now, what makes this relevant to the broader conversation is that endometriosis doesn't just result from estrogen dominance. It actively perpetuates it. The lesions themselves can produce estrogen locally through their own aromatase activity, independent of what the ovaries are doing. So, even as ovarian production shifts, the disease can continue driving its own estrogen environment. And here's where the gut comes in. The chronic inflammation that endometriosis creates doesn't stay contained in the pelvis. It affects the gut directly through adhesions and lesions that can involve the bowel, and indirectly through systemic inflammatory signaling that disrupts the gut lining and the microbiome. That microbiome disruption impairs what's called the estrobolome, or the collection of gut bacteria that plays a direct role in estrogen clearance. When the estrobolome is compromised, an enzyme called beta-glucuronidase gets upregulated, and estrogen that should be cleared gets reabsorbed instead. So you end up in a cycle where the disease drives gut dysfunction, and the gut dysfunction feeds the hormonal environment that sustains the disease. This is one of the reasons why women with endometriosis so commonly report GI symptoms. Bloating, bowel changes, food sensitivities, and these often get attributed to IBS or some other gut disorder, but never gets connected back to the hormonal picture. They're not separate problems. They're often driven by the same problem, just expressing in two different systems. Now, where the standard approach falls short is the conventional framework for women's hormonal health is largely built around two endpoints: the reproductive years and menopause. And what happens in between, that decade or more of shifting ratios and changing neurological response, rarely gets the clinical attention that it deserves. Part of that is structural. Standard panels check individual hormone values at a single point in time. They're not designed to evaluate the ratio of progesterone to estrogen across the cycle. They don't assess ovulation quality. They don't look at how hormones are being metabolized, whether estrogen is clearing efficiently through the liver or whether it's accumulating in forms that drive more symptom load. Part of it is also cultural. Women in this phase are often told that they're just stressed or that they're perimenopausal, but they don't have much follow-up. And what they're experiencing is just a normal part of getting older, which may be technically true in the sense that it's common, but common is not the same as inevitable, and it's definitely not the same as that nothing can be done about it. Hormones regulate the brain, the nervous system, sleep architecture, metabolic function, bone density, cardiovascular health, and emotional stability. These are not minor things. Waiting until estrogen drops dramatically to start paying attention means most women spend years symptomatic without answers and without support. So what does a more complete evaluation look like? I can't walk through a full clinical workup in a video, but I want you to know what the right questions look like so you can bring them to your provider. A more complete evaluation looks at progesterone and estrogen values in relation to each other, not just as isolated numbers and not just at a single point in the month. The luteal phase, or the second half of your cycle, is the most informative window for progesterone. A value drawn at the wrong time is essentially meaningless and doesn't show us what your progesterone response is. It also looks at hormone metabolism. How is estrogen being processed and cleared? This is where liver function becomes directly relevant, and it's a connection most people never hear about. The liver is the primary site where estrogen gets processed and packaged for elimination. It does this in two phases. In the first phase, it converts estrogen into intermediate metabolites. Not all of those metabolites are equal. Some are relatively inert. Others are more biologically active, more inflammatory, and more likely to drive the kinds of symptoms like breast tenderness, heavy cycles, mood instability that women are often just told are hormonal. In the second phase, those metabolites get bound to carrier molecules and prepared for excretion, primarily through bile and stool. If that second phase is sluggish, whether from poor nutrition, chronic stress, alcohol use, certain medications, or just a liver that's carrying more of a load than it can efficiently process, those estrogen metabolites don't clear the way they should. They recirculate, they get reactivated, and estrogen load in the body stays higher than it should be even when the ovaries are producing less of it. There's also a gut component to this that builds on what I mentioned with endometriosis. The estrobolome, or the collection of gut bacteria that supports estrogen clearance, plays a direct role here too. When the microbiome is healthy, it supports the final clearance of estrogen through the digestive tract. When it's disrupted from antibiotics, poor diet, chronic stress, or dysbiosis, beta-glucuronidase gets upregulated and it essentially uncouples estrogen from that molecule that we're supposed to carry it out of the body. That estrogen gets reabsorbed instead of eliminated. So you can have a woman whose ovaries are doing exactly what they should, whose liver is trying to do its job, and still end up with elevated estrogen burden because of what's happening downstream in the gut. This is why your estrogen looks normal on labs, but can still miss the picture entirely. What shows up in the serum doesn't tell you how estrogen is being metabolized, which pathway it's moving through, or whether it's actually clearing. That's what urinary hormone metabolite testing is designed to evaluate, and it's one of the more useful tools that we have in this space. And it looks at the broader context: thyroid function, cortisol patterns, blood sugar regulation, inflammation markers. Hormones don't work in isolation. The adrenal system and the ovarian system are deeply connected. Chronic stress, poor sleep, blood sugar dysregulation all drive hormonal imbalance. You can't fix one without addressing the others. This is the kind of evaluation I work through with my patients in depth, which is why I can't condense it into a single video, but this gives you a framework and it gives you better questions to bring to whoever is managing your care. So guys, the bottom line is this. What many women experience in their late 30s and 40s is real. It's hormonal and it's identifiable if you're looking in the right places with the right tools. This is a solvable problem, but it requires actually identifying what shifted, not just managing symptoms. If this video was useful, save it. Please share it with someone who may be going through this. And if you're reviewing labs with your provider and want a place to start, ask about your progesterone to estrogen ratio in the luteal phase. A lot of practitioners focus on individual values, and that ratio doesn't always come up unless you bring it up. At minimum, it's a great conversation starter. I'll link to the Instagram version of this in the description if you want the quick version, and I'll keep going deeper on these topics here. I very much appreciate you guys taking the time to listen to me. I know it's a lot of information. Hopefully this gave you some insight as to what's going on with your body. I'd be happy to help you out at Pinnacle Performance and Wellness, walk through some of this if you want to come and see me. Otherwise, we'll see you back here soon. Thank y'all again. Have a great day and God bless.